Hi, everyone. So my name is Mary Beaudin. I'm at Stanford. And it's my pleasure today to close the day with this talk on immune-mediated myopathies. So thank you for bearing with us. I hope you still have a little bit of energy. And thank you for being there today. So my only disclosure is that I'll discuss at the end of this talk a clinical trial that will be happening at Stanford, for which I'm one of the investigators. So the objectives for today is we're going to be discussing the clinical presentation, the workup, and the management of immune-mediated myopathies in the light of a patient history. The patient histories that I'll be presenting today are all fictive, but they could be patients that I would have seen in the clinic. They're very similar to other patients that I have seen. We'll also discuss future perspectives in the field, as has been done earlier, and obviously answer your questions. This is the main focus for today, so we'll make sure to keep some time at the end. So let's start with John. John is a 50-year-old man. 6 months ago, he started to develop weakness in his legs. Now he has difficulty getting up from a chair and cannot go upstairs. He gets tired easily when he walks. He has pain in his thigh muscles, and he has difficulty washing his hair due to shoulder weakness as well. So he's coming to you in clinic, and his question is, well, what's happening? So what are the next steps? And I think that today this has been covered a few times. The first thing is that we'll do a detailed history and physical examination. And although that seems very mundane, it's the best way that we have as neurologists to localize a lesion between all these different areas of the nervous system that can cause weakness. Because weakness, as we have discussed over and over, can come from the brain, the spinal cord, the nerve roots as they exit the spinal cord, the peripheral nerves, the junction between the nerves and the muscles themselves. And for the purpose of this talk, we'll focus on conditions that affect the muscles themselves, and we'll focus on conditions that are immune-mediated. When we examine patients and when we see patients that have myopathies, we're thinking about patterns because, interestingly, different diseases will tend to affect different muscles, not all in the same way. So this is sort of one example that we see. This is sort of a slide showing how certain muscles are most affected in inclusion body myositis, which is one of the diseases we'll be covering today. So these are shown in blue. So this is a disease that tends to affect finger flexion, wrist flexion. It tends to affect the quadricep muscles. And that can be contrasted to other inflammatory myopathies, which tend to affect a lot the shoulders, so very proximal muscles, and the hip girdle muscles. So these are the things that the physical exam can help to assess. Okay. So what are the next steps for John? Obviously, once we have done this very thorough clinical history and physical examination, we'll want to move on to more tests to narrow down our diagnosis on which muscle condition is affecting him. So typically, we'll do blood work. Blood work will include muscle enzymes, hormone levels, antibodies that are associated with muscle diseases. We might do an electrical test like Dr. Mupidi presented to you, which is an EMG. An electrical test is going to look both at the nerves but also at the muscles. So that's one of the things that we have to help us assess muscle disease. We may do muscle imaging with MRI or with ultrasound, and we may do a muscle biopsy. We may not need it in all cases, but that's going to be to really look at the muscle fibers and what's happening within the muscle to narrow down the diagnosis. So let's return to John. His exam showed weakness in the neck and the proximal limbs. His muscles enzymes were high. He had an EMG that showed an irritative myositis. And so he asked, "Doctor, can you explain to me what is myositis?" So myositis, it's a general term that talks about diseases that are caused by muscle inflammation. So we can say immune-mediated myopathy, it means the same thing. We can say idiopathic inflammatory myopathy, it also means the same thing. So you might see these terms being used interchangeably, and that's because they're actually referring to the same entities. Overall, as a group, there are heterogeneous groups of disorders characterized by muscle weakness and muscle inflammation. Overall, myositis is a quite rare disease. So this is a graph that compares it to other autoimmune diseases. It came from sort of the rheumatology literature. So what you see here on the right is rheumatoid arthritis. And if we compare that, the incidence, so the new cases every year that present of myositis, this is this orange band here. So it's a very rare disease. So the incidence, which refers to the patients that are newly diagnosed every year, is 0.2 to 2 people per 100 people in a year. The prevalence, which is all the people that are being affected with this disease at the same point in time, if we take a picture, that's 2 to 25 per 100,000 people. And why is that number so large? Because there's a lot of variation, is that different studies that look at different populations actually show a wide range of incidence and prevalence. So it seems that some countries and some populations are more affected than others. And some of the reasons for that, we don't actually always know. Myositis is an evolving concept, and you'll see that the classification of the diseases that we're talking about today has changed a lot in the last 40 to 50 years. So in comparison with myasthenia, which is very well defined, it's clear what we were dealing with. This is an evolving concept where as we progress in time, as we learn more about these diseases, about the antibodies that are found, we understand that there are actually subgroups that we didn't even know existed before. And so as the disease progresses, we're defining new subgroups of these different diseases. So I won't go in detail in that slide. It just shows that starting in 1975, Beaudin and Peter described and defined the diagnostic criteria for what we would call polymyositis and dermatomyositis. Dermatomyositis being the variant where there was some skin involvement as well, and polymyositis was where there wasn't any skin involvement, it was just the muscles that seemed to be affected. And at the time, we used to think that this was where it started and stopped, but then over time, you'll see that many other subgroups were defined. And I like this slide because this cartoon sort of shows that. So we used to have polymyositis, dermatomyositis, we thought it was all. But then over time, we described and recognized more some subtypes of myositis. So one of the first ones that was described was sporadic inclusion body myositis. And we recognized that it had a very different pattern of involvement, and some muscle groups were involved in that disease. It didn't progress like the other ones, and it didn't respond to the therapies like the other ones as well. After that, we described overlap myositis and antisynthetase syndrome, which are two sort of similar categories of diseases, and all the small letters and numbers that are there are all antibodies. So obviously today we won't be covering which antibody is linked with each disease. It's just to give you a broad overview that when we talk about myositis, there are a lot of different antibodies, and some of them sort of help us to narrow down the diagnosis to say, well, they're more associated with this or this disease. Some of the ones that are relevant is also immune-mediated necrotizing myopathies. These tend to have a fast progression. Sometimes they can be linked with statin exposure. And you can see here sort of these colored boxes showing that some of these diseases can be associated with skin involvement, some can be associated with lung involvement, and some can be associated with malignancy, and sometimes the antibody itself helps us to sort of narrow down and better understand what organ systems could be affected. And here on the right, just showing that even this table here doesn't show all the picture. There are even more myositis types. This is sort of the same idea, so I won't go in details over that slide. There are so many cartoons about different types of myositis, how they overlapped, but just sort of remembering a little bit, we have polymyositis, which is sort of a non-specific myositis. Often we won't really find any specific antibodies, but it has this general presentation. Overlap myositis has very typical antibodies that are associated with it, dermatomyositis as well, and it can be associated with cancer, and immune-mediated necrotizing myopathy, and then inclusion body myositis, which we'll cover a little bit later. This shows a little bit that myositis, although we as neurologists tend to think of it as a disease mostly of weakness and muscle disease, but we always keep in mind that there's this multi-system involvement. So although sometimes the patient will complain mostly of their muscles, we know that some of these specific subtypes can be associated with skin involvement, as I mentioned. Some of them can have lung involvement. Some of them can have heart involvement. Some can have changes in how the blood vessels react in the limbs. Some of them can have difficulties with swallowing. And that sort of gives a broad overview to how sometimes these diseases are actually causing autoimmunity not only in the muscles, but also in other organs. Some of the skin findings that we can find, for example, that are very typical of dermatomyositis are shown here. So there can be sort of red and scaly lesions over the knees, all the extensors, the finger extensors, that's quite typical. In anti-synthetase syndrome, sometimes there can be very dry skin over the fingers, and also that can be some of the clues. So that's one of the reasons why we always look a lot at the skin, because sometimes there can be some hidden clues that even the patient themselves may not think it was related to their weakness. Muscle biopsy. And that might be one of the things that some of the patients here have discussed with their provider. Dr. Mupidi discussed earlier that sometimes we can do nerve biopsy when we have a nerve issue, and sometimes when we have a muscle issue, we'll discuss muscle biopsy. The good fact about muscle is that it regenerates. So even if you do a muscle biopsy, that muscle is not lost forever. It will just sort of rebuild itself. And so that sort of gives us an easier access to the muscles than to the nerves. So this is what a muscles looked like. So it's sort of linked by a tendon to a bone. It has many different fascicles that are themselves composed of many different muscle fibers, which are like very large cells that have different contractile units, which are the myofibrils. And all of these can make the muscle sort of contract, shorten, and that's what's going to give us movement over time. When we do a muscle biopsy, we'll try to get a small piece of these, and we're going to be looking at them sort of in that axial cut so we can see different myofibrils, different cells. So this is what muscle biopsy might look like in myositis, and obviously today the goal is not to go over all of what muscle biopsy might look like in myositis, but it can give us some very useful clues to the specific disease that we're dealing with. And sometimes that's going to help us sort of guide the treatment that we're going to be offering. So this is what we may see in necrotizing myopathy, where there's all these pale cells, there's sort of pinkish cells that are paler. These are muscle cells that have been attacked and that are now dying because of that attack. So that sort of narrows down to, oh, there's like very severe attack to the muscle cells. In a different disease, this is inclusion body myositis. There can be inflammatory cells within the muscle itself. So you can see here, all these little purplish dots are all inflammatory cells, lymphocytes, macrophages that are attacking the muscles, and that shouldn't be there. So now let's return to John. He had positive antibodies to HMGCR, which was one of the antibodies that are associated with a specific disease. His muscle biopsy showed a necrotizing myopathy. And so his neurologist diagnosed him with immune-mediated necrotizing myositis or myopathy, which we also call necrotizing autoimmune myositis. And so he says, "Doctor, how do we treat this?" And the treatment for myositis, and I think that this was sort of highlighted by Dr. Goyle earlier for myasthenia, this is a road of many different roads, and so there is not one size-fit-all treatment for myositis. It's going to depend on the myositis subtype and the antibody that we found, the severity of the symptoms, the patient's other medical conditions, the response to other treatments that might have been tried before, the risks of side effects, because sometimes stronger treatments have more risks of side effects, and then insurance reimbursement sometimes is also part of the things that we have to consider. So this is not a one-size-fits-all, and this is why today I cannot tell you, you have to start with this, then you have to do this, because obviously it's going to vary, and that's why it has to be very individualized. But in general, the treatments that we can use in myositis, and many of them have been mentioned earlier, both from Dr. Mupidi's talk, from Dr. Kang's talk. So there are all these non-specific immunosuppressive drugs that we can use in other conditions as well, and those include corticosteroids, IVIG, plasma exchange, oral immunosuppressive agents, including methotrexate, mycophenolate mofetil, azathioprine, tacrolimus, cyclosporine. And in very severe disease, we can use rituximab and cyclophosphamide. So this is what we're now using. And as more and more we learn, and as new therapies get approved for other immune-mediated diseases, then we look at, hey, could these therapies be useful in myositis too? And we'll sort of talk a little bit about that at the end. But yes, that's where the field is going, and we're hoping that we're going to have other more targeted therapies in the future. So let's return to John. So he was started on prednisone, IVIG, and methotrexate. He's seen again 3 months later. He's feeling better, but he still has leg weakness. He's not able to go up more than 5 steps at a time, and he still has a little bit of thigh pain. So he says, "Doctor, when will these symptoms go away? When will I be cured from this disease?" And unfortunately, this is not always a straightforward path. When we treat autoimmune diseases, we aim for resolution of the symptoms, so getting patients into remission, that they're able to do all their daily life. And at the same time, we have to consider the burden of the medications we're giving and the potential side effects that the patient may have. So in an ideal world, we would have treatments that are very efficient and that have no side effect burden so that the patients can return to normal life. And sometimes there's a little bit of trial and error in finding that right balance of we may add more medications at the beginning to try to get the disease under control, then try to taper them off slowly. And sometimes the disease may get more active as we taper. So there's a little bit of fine-tuning there, and that's why sometimes this is not straightforward. I wanted to briefly touch base on the value of physical exercise that was discussed this morning, and it's interesting that in myositis, we have actually 2 small but still randomized clinical trials that looked at what's the value of helping patients get physically active and doing endurance and training. And so this is 2 studies from 2013 and 2014, so starting to be a little bit old, but still that showed that if you do a 12-week or a 24-week program, patients have benefit in their overall fitness, in their aerobic performance, and then even in that study on your left, there was even a little bit of benefit on the disease activity itself. So definitely this shows that this is safe, and this is beneficial for the patients if they're able to have guided exercise, to do it progressively, obviously, but if they're able to resume physical activity in a disease-appropriate manner, then it's beneficial for their overall health and function. So we'll talk a little bit about Helen. So Helen is a 60-year-old woman. 4 years ago, she started to develop weakness in her legs. When she was hiking, she would have knee buckling when going downhill. This has progressed slowly over time. Now she has difficulty going upstairs or rising from the floor. She denies having any pain, and she also reports having difficulty opening jars. So she also comes to clinic and she asks, what's happening? So we go through the same process as we went for the prior case. And when we look at her story, her exam showed weakness predominating in the quadriceps and the deep finger flexors, which is a typical pattern for inclusion body myositis. She had positive antibodies to anti-5C1A or anti-CN1A, which is also associated with this disease. She decided to undergo a muscle biopsy to confirm the diagnosis and because she's interested in research. And so she asks, "Doctor, how do we treat this?" And unfortunately, inclusion body myositis is sort of a zebra within the other inflammatory myopathies in that at this point in time, we don't have an efficient treatment to treat IBM. So this is a disease that has two pathogenic processes going on. There's an immune process, but there's also a probably degenerative process. And so far, when we've tried these non-specific, broad immunosuppressive therapies, we didn't have any success in improving how this disease evolves over time. So this is shown here. IBM has two different processes going on. There's immune-mediated process with a lot of muscle inflammation, inflammatory cells within the muscles, but there are also degenerative features showing protein accumulation and things that seem to be sort of relentlessly progressive and not really immune-driven. And so the question here is often the chicken or the egg. Is this an immune process that once it has started, starts to have this secondary degeneration occur? Or is it a primary degenerative process, and once there's degeneration, there seems to be like scavengers and cleaning and sort of a secondary inflammatory process? And so where is the field going? There are many questions that remain to be answered in the field of myositis. One is to better understand the risk factors and the mechanisms of disease. We talked about that in myasthenia. In myositis, it's the same thing. Why is this occurring to me? Probably there's a mix between some environmental things we are exposed to and our genetics that make us more vulnerable to these autoimmune diseases. We're still looking in myositis to establish reliable diagnostic criteria to define each subtype and have more consistency in between how different people will qualify each myositis so that we can do good research. We're still looking to identify other specific autoantibodies because we have many patients that, despite having this very typical presentation, don't have any autoantibodies that we, as of now, know of. And then finding more effective and targeted therapies. And I think that this is very promising. There are currently ongoing clinical trials looking at efgartigimod in certain myositis. So I think that there is interesting research going on. Many of these diseases are antibody mediated. So as Dr. Mupidi talked about earlier, some of the things that we have learned from other immune diseases will probably be applicable to myositis. And I just wanted to briefly touch on, I talked about how unfortunately inclusion body myositis is a zebra in that it has no disease-modifying therapy at this time. At Stanford, we're going to be starting a clinical trial, a phase 2-3 study looking at ABC008, so one molecule that is targeting these very toxic T cells that are invading the muscles in IBM. And we're hopeful that over time that this is going to show progression. So the PI for this study is Dr. Goyle, and there's a contact here. So if you are interested in this study, let us know.